The topic of our discussion is alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency is a disease that occurs from the deficiency of a specific protein known as alpha-1 antitrypsin. This alpha-1 antitrypsin is a glycoprotein which is produced in the liver, and it is a serine protease inhibitor. The protein is composed of 394 amino acids, and it protects the tissues from proteolytic damage. Alpha-1 antitrypsin inhibits certain neutrophilic enzymes such as neutrophil elastase, cathepsin G, and proteinase 3. All of these enzymes are proteases in nature, and they are secreted by the neutrophils in case of inflammation. These enzymes destroy the pathogens as well as the host tissues. So alpha-1 antitrypsin deficiency disease occurs due to misfolding of alpha-1 antitrypsin proteins. So these proteins are malfunctioned and they start to accumulate inside the hepatocytes. This accumulation results in hepatocytes damage, ultimately leading to cell death. The disease occurs in various forms, but clinically the most significant disease has point mutation in 342 amino acid. In this case, glutamine amino acid is replaced by lysine. So this point mutation results in dysfunctional alpha-1 antitrypsin protein, which is misfolded and it polymerizes. This misfolded alpha-1 antitrypsin protein is not migrated from endoplasmic reticulum to Golgi apparatus. Thereby, it starts to accumulate inside the endoplasmic reticulum, resulting in increased endoplasmic reticulum stress. This excessive stress triggers apoptosis of hepatocytes, thereby resulting in liver tissue injury. Therefore, the disease first of all damages the liver due to accumulation of misfolded and malfunctioning alpha-1 antitrypsin protein. Moreover, alpha-1 antitrypsin protein inhibits the neutrophilic elastase enzymes. Hence, it also prevents injury to certain tissues that contain elastin protein. In alpha-1 antitrypsin deficiency, this deficiency results in increased elastase enzyme activity, and it begins to accumulate inside the tissues since there is loss of inhibition by alpha-1 antitrypsin. This elastase enzyme starts to damage the elastin protein present inside the alveoli. The excessive damage to alveoli results in loss of structural and functional integrity of the alveoli. So alveoli and alveolar duct is converted into a sac-like structure. This sac-like structure is formed due to loss of elastin from the alveoli, and therefore it has lost its structure and it is incapable to perform its normal functions, which is the exchange of oxygen and carbon dioxide. This saccular dilation of alveolar sacs is known as emphysema. So alpha-1 antitrypsin deficiency also results in pulmonary damage in the form of emphysema. The histological picture of the liver reveals round to oval cytoplasmic inclusions in the hepatocytes. These inclusions appear acidophilic on H and E stains. Moreover, these inclusions are also PAS or periodic acid shift positive. As you can see here, this is a hepatocyte, and this magenta colored inclusion is actually a misfolded alpha-1 antitrypsin protein. In the early stage of the disease, the mutant proteins or misfolded proteins can be demonstrated in the periportal hepatocytes. The disease has variable features on histology ranging from cholestasis to acute and chronic hepatitis. Another particular feature about alpha-1 antitrypsin deficiency is that they contain steatotic hepatocytes. As you can see here, this is a steatotic hepatocyte, and these hepatocytes are filled with excessive lipid and fats. Therefore, they appear swollen, and steatotic hepatocytes are also present in alcoholic liver disease and non-alcoholic fatty liver disease. In the late stages of the disease, liver cirrhosis is also present. The disease is autosomal recessive and the age of presentation is variable. In newborns, cholestatic jaundice is the first complaint, which occurs in almost 10 to 20% of patients of alpha-1 antitrypsin deficiency disease. Moreover, in adolescents, the patient presents with hepatitis. This hepatitis is either acute and it subsides, or it progresses into chronic hepatitis. In case of chronic hepatitis, there is a vast chance to progress into liver cirrhosis and complete end-stage liver disease. In the patients who progress to liver cirrhosis, there is a 2 to 3% increased chance of developing hepatocellular carcinoma. The disease also affects pulmonary tissues, specifically alveoli, which is characterized by the emphysema. Emphysema presents as productive bouts of coughing, wheeze, difficulty in breathing, shortness of breath, and moreover, in certain cases, there is a history of weight loss. The disease is occurring as a result of saccular dilations of alveoli, making them unfit for the exchange of gases. Paniculitis means inflammation of subcutaneous fat. The patients with alpha-1 antitrypsin deficiency are advised to refrain from smoking, and the only treatment option in case of full-blown emphysema is lungs transplant, and in case of liver cirrhosis is liver transplant. So this brings us to the end of discussion about alpha-1 antitrypsin deficiency disease.